Okay, in this video, let's take a look at the primary cause of jaundice. So as a brief review, our red blood cells, as they become senescent, are taken up by splenic macrophages. These splenic macrophages extract the iron from the heme after degrading the hemoglobin protein, and then the heme that is left behind, the macrophage will degrade that down to bilirubin. Then the bilirubin is placed out into the blood, is secreted, and the liver picks up the circulating bilirubin. Now this portion here, prior to the liver taking up the bilirubin from the blood, is called the prehepatic phase of heme degradation. At this point, the bilirubin is unconjugated. Unconjugated is termed indirect in clinical laboratory tests. Now, once the bilirubin has been taken up by the liver, by the hepatocytes, the liver will then conjugate the bilirubin into bilirubin diglucuronide. The enzyme that does this in the hepatocytes is called UDP glucuranosyl transferase. There are a couple of genetic disorders that affect this enzyme, and we'll look at that in a second. Now, once we have our conjugated bilirubin diglucuronide, which is termed direct bilirubin in clinical lab tests, this will be secreted into the bile, and from the bile it will be stored in the gallbladder, and upon CCK, cholecystokinin stimulation, the contents of the bile, including the bilirubin diglucuronide, will be secreted into the duodenum. Now, if we back up here, we saw the prehepatic phase of heme degradation. If we look at the liver, this is considered the hepatic phase. And the hepatic phase is simply the phase where the hepatocyte is taking up the bilirubin inside the hepatocyte and conjugating it to form bilirubin diglucuronide. Once we have this waste product secreted into the bile, proceeding down the bile duct, then we have the post-hepatic phase. Essentially, this is after the hepatocyte has done its conjugation job. This will become important in diagnosing the stage of jaundice. So now let's consider the levels of bilirubin. If upon lab tests of plasma we see an increase in indirect bilirubin, so that the majority of the free bilirubin that is measured in the plasma is found to be indirect or unconjugated, there are a couple of causes for this lab result. One could be due to excessive hemolysis. Hemolysis is, of course, a pre-hepatic event. The red blood cells, for various reasons, are lysing at an increased rate. Primarily, could be due to injury or a chemical means. The key is that the red blood cells are lysing, releasing their heme. The heme is being broken down by macrophages to bilirubin. The bilirubin is now saturating the hepatic pathway. Of conjugation. This leads, of course, to increased indirect bilirubin in the blood, resulting in higher levels of indirect unconjugated bilirubin. All of this, of course, is happening in the pre-hepatic stage. The other mechanism of increased indirect bilirubin is because of conjugation defects. Conjugation defects can, of course, only occur in the hepatic phase because the conjugation occurs intracellular in the hepatocyte. There are two genetic disorders. One is called Gilbert syndrome, and Gilbert syndrome is a small decrease in UDP glucuranosyl transferase activity. Now, being a small decrease in this activity tends not to manifest into any severe clinical symptoms, but it does lead to mild jaundice. Mild jaundice because the conjugation of the bilirubin is decreased. That being the case, the indirect unconjugated bilirubin will be in excess of normal. The bilirubin will then deposit into skin, leading to the characteristic jaundice that we see. The other genetic disorder is called Crigler-Najjar syndrome. This is a result of a substantial decrease or absence of enzyme activity. So the transferase enzyme in this case has a much reduced or no activity. With no activity, this is going to lead to substantial levels of unconjugated bilirubin, which, of course, is toxic because bilirubin binds very avidly, being so hydrophobic, to proteins and causing protein dysfunction. This disorder is fatal compared to Gilbert syndrome, which leads to mild clinical symptoms. So now that we discuss pre-hepatic issues, hemolysis that lead to elevated bilirubin levels, the hepatic phase of poor enzyme activity or incomplete enzyme activity for conjugation leading to elevated bilirubin levels? What about increased conjugated or direct bilirubin? The hint would be this is considered a post-hepatic issue or error. Elevated conjugated direct means that the hepatocytes are functioning fine. So the liver is processing the bilirubin as it should. The problem here, the most common problem, is a biliary obstruction. Biliary obstruction could be a gallstone that is lodged in the common bile duct, or it could be gallbladder infection or biliary fibrosis. The key here is that elevated direct bilirubin, elevated conjugated bilirubin, is a post-hepatic event because the liver is fine. The liver is functioning normally. Now the other issue here that we didn't talk about is the indirect bilirubin. This could also be the most serious is liver disease, such as cirrhosis. But that's at the very far end of the spectrum, and there's going to be clinical symptoms far earlier than elevated indirect bilirubin.